Hello, I'm Dr. John Kabashigawa from the Cedars-Sinai Smith Heart Institute, and my co-moderator is Dr. Karan Kush from Stanford University. Together, we would like to welcome you to this American Journal of Transplantation Journal Club, featuring two papers associated with the theme of T-cell mediated rejection. We have two exciting papers to present and discuss. The first paper is Evolving the Surveillance and Workup of Heart Transplant Rejection, a real-world analysis of the Molecular Microscope Diagnostic System. And this paper will be presented by Dr. Gregory Milligan from Baylor University. A brief background on this paper. Well, when heart transplant biopsies are performed, the measurement of intragraft gene expression, mRNA transcripts, has significant potential to improve biopsy interpretation. The molecular microscope is a central biopsy diagnostic system that uses genome-wide microarrays to define T-cell mediated rejection, antibody mediated rejection, and parenchymal injury, and compares a biopsy to a reference set using ensembles of predefined machine learning derived algorithms. The molecular microscope correlates with histology, but often with discrepancies given the inter-observer disagreement in the histologic diagnosis of rejection. The manner in which it is applied in clinical practice has not been established. The paper by Milligan and colleagues delves into the real-world assessment of this recent diagnostic. Now, the second paper is entitled Clonal Hematopoiesis Confers an Increased Mortality Risk in Orthotopic Heart Transplant Recipients. And this paper will be presented by Dr. Phyllis Billia from the University of Toronto. Now, clonal hematopoiesis involves mutations in genes that are involved in epigenetic modifications, signaling, and DNA damage repair. It has emerged as a major independent risk factor in atherosclerotic cardiovascular disease, thrombosis, and heart failure. Clonal hematopoiesis involves increased myeloid cell inflammatory responses and inflammasome activation. The discovery of the association of clonal hematopoiesis with cardiovascular disease makes it natural to apply to heart transplant patients with their inherent inflammatory complications of acute and chronic rejection, which impacts mortality. This paper by Billia and colleagues will delve into this application. So let's get started. Dr. Greg Milligan, please present your paper.
All right, thank you. All right, thank you to Dr. Kabashigawa for the introduction, to Dr. Kush for moderating as well. Thank you to the editors for the opportunity to present this paper on our experience utilizing the molecular microscope in our real-world heart transplant population. I have no disclosures for this talk. This is the paper that we'll be discussing today, entitled Evolving the Surveillance and Workup of the Heart Transplant Rejection, a real-world analysis of the Molecular Microscope Diagnostic System, recently published in the American Journal of Transplantation. Objectives for today, pretty straightforward: understanding the study rationale and design, understanding the study results, which was where we'll spend the bulk of the time here, including concordant and discordant findings, and then discuss these findings as it pertains to clinical implications of these findings. We'll start with study rationale and design. And really the rationale from this study really stems from what are known and well-documented limitations of the histopathologic assessment of EMB specimens, and including but not limited to sampling error and really just the human subjectivity of pattern recognition for histopathologic assessment. And so it's believed that in large part these limitations may yield to this quote-unquote biopsy negative rejection entity, which is estimated anywhere between 1% to 2% of transplant to be incident upon anywhere between 1% and 2% of transplant recipients. And so we've seen an emergence of diagnostic modalities through the years, including cell-free DNA, DSAs, gene expression profiling, and most recently, the Molecular Microscope Diagnostic System, otherwise known as MMDX, which you'll see referred to it as such throughout the paper, and I'll refer to it here as such moving forward. And this is obviously the topic, a primary topic of this paper that we'll be discussing. I wanted to dedicate just one slide. Dr. Kabashigawa did a great job introducing MMDX as well, but just one slide just so that we're all on the same page in terms of what is MMDX. And in essence, it's a molecular diagnostic modality that assesses the health of the allograft. And it does so by analyzing gene expression patterns via microarray analysis of the intragraft mRNA transcripts. And so a little bit about the process. So we obtain these specimens at the same time we obtain your traditional histopathologic EMB that we send to our path lab. However, these specimens are sent to a reference lab, in which they're analyzed against thousands of different mRNA transcripts to ultimately report to us, the clinicians, the probability of the graft's T-cell mediated rejection, AMR, antibody-mediated rejection, injury, or of course, normal healthy tissue. That said, the performance of MMDX is largely unknown as it relates to other diagnostic modalities, and that really forms the foundation of the report in which we're discussing today. So a little bit about our design. We retrospectively evaluated whether MMDX performs in agreement with other validated modalities in the surveillance and workup of transplant rejection. We evaluated 233 consecutive specimens obtained between February 2019 and December 2020. And heart transplant recipients spanned a duration between 9 days post-transplant and 23 years post-transplant. And these included both surveillance and quote unquote for-cause biopsies in the clinical suspicion for rejection. Specimens were included in the analysis if we had an adequate paired MMDX and EMB specimens available. So I wanted to define how how we defined rejection to then subsequently define whether or not that the modalities agreed with one another. And so on EMB, rejection was defined if there was a T-cell mediated rejection grade greater than or equal to 2R, antibody mediated rejection if grade greater than or equal to PAMR greater than or equal to 1, and mixed rejection if there was combined AMR and TCMR. MMDX is reported as TCMR, AMR, mixed rejection, injury, or of course normal healthy tissue, donor-derived cell-free DNA was deemed to be rejection if the value was greater than or equal to 0.20%. Concordance was simply defined whether or not the modalities agreed with each other. If they agreed based on these definitions, they were deemed in agreement and concordant. If they were not, then they were deemed discordant. We'll move into results at this point. I mentioned that there was 233 paired specimens available for review. We had to exclude 5 due to inadequate sampling of the EMB, which yielded us 228 specimens paired EMB and MMDX in our analysis from 135 subjects, of which 30% of these specimens were obtained quote unquote for cause and the suspicion for rejection. So this is the raw results here on the left-hand side, in which you can see how each modality classified rejection in this cohort. And I'll leave this here for your review, but I wanted to spend a little bit more time reviewing how these modalities agreed with one another or didn't agree with one another. And so I mentioned that there was 228 paired specimens between EMB and MMDX, in which there was an 84% total agreement between these two modalities. Of the 228 paired specimens, we had corresponding cell-free DNA for 176 of these specimens. In total, there was 61% agreement between all 3 modalities. There was 72% agreement between MMDX and cell-free DNA, and 70% agreement between EMB and cell-free DNA. So this is kind of one of our central tables here in which kind of further defines where these 2 modalities or 3 modalities agreed with one another in terms of a 2-way agreement, or they didn't agree with one another. And so you can view each row as sort of its own 2-by-2 table of sorts. And so this top row here is comparing MMDX to EMB and how they both compared with one another. And so you can see in the top that EMB and MMDX agreed that there was no rejection in 167 specimens, and they agreed that there was rejection in 24 of the 228 specimens. So that yielded a moderate agreement in classifying rejection and an 84% total agreement that I previously mentioned. You'll also note that there was among the discordant specimens, there were 37 discordant specimens. And you'll note that this was largely due to an increased classification of rejection by MMDX as compared to EMB, which we found somewhat interesting, and we'll talk about a little bit later. When moving down the table, MMDX versus cell-free DNA and EMB versus cell-free DNA, there was ultimately slight agreement in classifying rejection. And in each of these cases, the discordant specimens were largely due to increased classification of rejection by cell-free DNA as compared to its comparator. And in the case of EMB versus cell-free DNA, it was the vast majority, 52 of 53 specimens were discordant as a result of increased classification of rejection by cell-free DNA. So diving into a little bit more of the characteristics of concordant and discordant results of our paper. This is a busy table, but there's a few things I wanted to highlight, and that was that I mentioned that there was among the discordant specimens between MMDX and EMB, that this was due to an increased classification of rejection by MMDX. And this points out that this was essentially across the board of all types of rejection and not really due to any one particular type of rejection. Additionally, among the discordant specimens between EMB and MMDX, you'll notice that the discordant specimens tended to be obtained much later, post-transplant at a median of 12 months. Additionally, I wanted to point out that amongst the discordant specimens, we noticed that there was elevated cell-free DNA kind of across the board in terms of all two-way comparators. And when cell-free DNA was utilized as a two-way comparator between cell-free DNA and MMDX and cell-free DNA and EMB, you'll notice that the discordant specimens tended to have or tended to be obtained much earlier post-transplant at a median of 1.5 months in both circumstances. This figure demonstrates how the third modality performed amongst discordant cases only. So again, we go back to our 37 discordant specimens between MMDX and EMB. And in this case, the cell-free DNA was the third modality that was applied, and it agreed with MMDX in this case in about half of patients, in which nearly all of which were in favor of rejection. Moving down the line, MMDX versus cell-free DNA and EMB versus cell-free DNA, you'll notice that EMB and MMDX tended to agree with one another, and it tended to favor the absence of rejection. However, as we move down the line, you'll notice that when EMB and cell-free DNA were discordant in panel C, MMDX tended to, in the patients in which MMDX was concordant with cell-free DNA, it tended to favor rejection in all of these patients. This figure here is a distribution of cell-free DNA levels by the presence or absence of rejection on either EMB on the left two panels A and C, or MMDX on the right two panels B and D. And so the bottom left in panel C is a composite of whether rejection was present, all rejection was present as compared to no rejection. And you'll notice significant elevations in cell-free DNA levels as compared to no rejection. And you'll notice as you move up to panel A, this was accounted for in all types of rejection. Cell-free DNA was elevated. Moving to the right-hand side, panels B and D, when the composite was looked at with all types of rejection on MMDX classification, cell-free DNA was significantly elevated. However, as you move up to panel B, you'll notice that when MMDX was classifying T-cell mediated rejection, there was not noticed to be a significant elevation in cell-free DNA. And so the composite elevation of cell-free DNA in all types of rejection was really carried by AMR and mixed rejection. And so we report a 61 concordance amongst all three modalities. Obviously, this presents a clinical challenge for us. And so where do we take this information? And so I wanted to touch on our center and move on to the kind of the final talking point of the talk. And so our center manages these patients with largely an interdisciplinary immunology meeting in which we bring these challenging patients to the table, discuss among transplant immunologists, transplant pharmacists, transplant cardiologists, and so forth, to really get a unified plan in managing these patients. And so for us, we report that MMDX positivity contributed to a change in management in 5 patients with suspected rejection who maintained a negative histopathologic biopsy result throughout, and contributed to an earlier management of 3 additional patients who ultimately experienced a subsequent confirmatory positive EMB. A few discussion points. So MMDX and cell-free DNA were more likely to classify rejection relative to EMB. We won't have time to kind of dive into all the possible reasons for this. Although one possibility exists is really the objectivity of these molecular techniques as compared to the subjectivity of traditional histopathologic assessment. We noted that there were 37 discordant specimens between MMDX and EMB, of which the vast majority, 86% of which, were classified as rejection by MMDX. This is largely speculative, but it's possible that MMDX may represent early phases of rejection, as genetic activation may precede a robust inflammatory infiltrate seen on EMB, although this requires further elucidation and is really speculative at this point in time. We also note that discordant samples were marked by elevated cell-free DNA levels pretty much across the board, which I noted previously, and we just wanted to remind that there's a broad differential and should be considered, rejection being one of them, but other etiologies being vascular and etiology or infectious and etiology. So in conclusion, our findings demonstrate a degree of agreement amongst all modalities. However, significant systematic differences were observed. And the data really supports the utilization of multiple diagnostic modalities in the management and surveillance of these difficult patients. The Trifecta Heart trial is currently enrolling. Our center is enrolling at Baylor University Medical Center in Dallas as well, and hopefully we'll elucidate these findings further as well. I would like to thank my co-authors on this paper for all their efforts towards this important work, as well as all faculty at Baylor University Medical Center, as they contributed to this important work by way of patient care and specimen acquisition. Again, thank you to the editors, and thank you for your time.
Thank you very much, Dr. Milligan. Now we'll move on to our next presentation. Clonal hematopoiesis confers an increased mortality risk in orthotopic heart transplant recipients, to be presented by Dr. Phyllis Billia. Please.
Thank you very much to the American Journal of Transplantation and both Dr. Kabashigawa and Dr. Kush for this incredible opportunity. I'm very excited to present our work here because I do think it actually can change the paradigm for all patients undergoing solid organ transplant, not just heart transplantation. So with that opening comment, I have nothing to disclose that's relevant to this publication. Now, just to reiterate some of the introduction that was given by John, and what is really clonal hematopoiesis? And I think this graphic really illustrates it, but very simply, and that is, as we age, hematopoietic stem cells actually acquire mutations. Now, there are specific mutations that lead to an expansion of the clonal blood cells that are derived from them that then creates this inflammatory environment. Why this is important is because that we know that inflammation is being linked to many health conditions, from diabetes, cardiovascular disease, and further conditions such as blood cancers like leukemia. So we then began looking at specific populations of patients where pathogenesis of their disease was linked to inflammation, as one of the key populations that we thought about was actually transplantation, and in particular, heart transplantation. In the literature, there's very little that has been published with respect to clonal hematopoiesis and transplantation. The link is rather to other inflammatory conditions, such as I mentioned, atherosclerotic disease and cancer. But in this remote paper, in a murine model of kidney transplantation, by blocking inflammation through the blockade of IL-6 and TNF-alpha, we see that there's a greater graft survival as shown in this graph. And when you block both IL-6 and TNF-alpha, there's a synergistic effect. When we move to heart transplant recipients and look at gene expression of chemokines and receptor expression in endomyocardial biopsies, we see that there's a link in the grade of rejection and the degree of expression of inflammatory cytokines. And more recently, it's a reasonable expectation to think that clonal hematopoiesis could affect graft function post-transplant. And this may not be just due to enhanced inflammation, but also due to the fact that most patients are living in a chronic inflammatory state pre-transplant that could either be a result of clonal hematopoiesis that it has been acquired, or an increase in the degree of clonal hematopoiesis. So, in looking at the transplant literature, there was really only one paper that looked directly in patients with post-liver transplant. And in this paper, they found that only in a very small cohort of 9 patients, 5 of these 9 patients actually harbored CH mutations and a worse outcome. So the potential implications, therefore, in looking at this in heart transplant recipients are to think about could the presence of these mutations affect a few outcomes post-transplant, namely rejection, graft function, acquisition of malignancies, opportunistic infections, and then overall survival. So we then took it upon ourselves to actually conduct a preliminary study to examine this in heart transplant recipients at our institution at the Ajmer Transplant Center. So this is a retrospective design where we actually looked at heart transplant recipients with biospecimens within 6 months of transplant with a minimum follow-up of a year. And we were able to determine that we had such specimens from an initial sample size of 127 patients. Now, if we look at the characteristics of these patients, we see that within this cohort, out of the 127, we have 26 that had clonal hematopoiesis, whereas 101 didn't. And that this was estimated at, in the general population, what we're looking at is about 5% of the patients in this age group, which is in the, around the 5th decade of life, will have CH. This is a markedly increased number. And in this table, we find that there's 3 significant differences from a statistics perspective between those patients that had clonal hematopoiesis and those without. Firstly, we see that those with CH were statistically older, 54 years of age versus 48 years of age. And interestingly, patients with CH were followed longer And I think this was just the randomness of the design of the study. And there was a higher percentage of patients with CH that were EBV positive. So when we were able to look at the cohort, instead of 5% of expected representation of clonal hematopoiesis in the general population, we see that in our cohort, we had up to 20%, so a fourfold increase of patients that had undergone a heart transplant. And looking at the specific mutations, we see that the ones that predominate are the ones in DNMT3A, SLXL1, and TET2. Most patients had one mutation as opposed to multiple mutations. When we considered the clinical outcomes and we adjusted for age, which is an important co-founder in this, we looked at the important clinical outcomes, including CMV infection, rejection, malignancy, cardiac allograft vasculopathy, and mortality. We see that in our small cohort that there is actually, despite the small study, that we were able to see an association with higher grade of cardiac allograft vasculopathy and 1-year mortality. And specifically, when we looked at our survival and follow-up, we see that we look at this more closely. If we look at the unadjusted hazard ratio for all comers in our study, we have a 3.1 hazard ratio. But when we adjust for age, the presence of chronic kidney disease and heart failure etiology, this adjusted heart ratio is now 2.9. And when we then add in a immunosuppressive regimen at the end of 1 year with age, the hazard ratio is actually 5.9. So in conclusion, what we have is a higher prevalence of clonal hematopoiesis in this particular patient cohort, which is incredibly interesting. And it's associated with cardiac allograft vasculopathy and mortality at 1 year. But it's important to think about these complex relationships between clonal hematopoiesis and inflammation being responsible for these outcomes, whether it is a predisposition prior to transplant that leads them to that state, or a change in the trajectory during this chronic inflammatory state, which is transplantation. Our other outcomes are actually limited by our small study design, and we're limited by the retrospective nature of this small sample size with lower number of events, and this is more of a hypothesis generating study. But we wanted to present this paper because we do think that this could be an important biomarker of risk going forward, and something that should be planned potentially for all patients who are going to be listed for organ transplantation, because it could change our way that we think about surveillance in our patients. And we have been currently expanding this study to all patients undergoing solid organ transplant at our own center, and expanding it to a sample size of 1,500 patients. So that study will be coming out in the next 6 months. And this work cannot be done without the incredible work of an incredible team, Dr. John Dick and Sagi Abelson, who actually made the initial discoveries of clonal hematopoiesis and the link to leukemia, as well as the work of Fernando Scolari and Darshan Brambad, who were the postdocs who drove most of this work. Thank you.
Thank you so much, Dr. Billia. And now to introduce Dr. Karan Kush, who will be the discussant.
I'd like to thank our two paper presenters today. These are really fascinating articles that I think represent the field of what's happening in heart transplant research these days. And both of these papers actually are applicable to solid organ transplant in general. So to start out with Dr. Milligan's presentation, he gave a really nice real-world experience of using non-invasive diagnostics as well as the molecular microscope in the field of heart transplant. And as you all know, we've entered this era of molecular diagnostics, which I think really helps us improve and refine our diagnosis of rejection. Many of these markers are exquisitely sensitive for early forms of immune activation, such as what we've seen with the gene expression profiling tests, and also for very early graft injury, as in cell-free DNA. And these changes occur earlier than changes on endomyocardial biopsy. And so the hope is that using these molecular assays will really allow us to pick up early signs of immune activation, early graft injury before biopsy-based findings, and also using tools such as the molecular microscope to really refine our diagnoses. But unfortunately, I think as many of us have seen, these assays are not always congruent and often give results that point in different directions. And so this is really where the work by Dr. Milligan and his group is very helpful because it gives us data on how to put the results of these studies together to help us come up with a unified diagnosis. And finally, to move on to Dr. Billia's work, clonal hematopoiesis has really come onto the scene in the last few years as a novel risk marker for cardiovascular disease in general. And a lot of the work has been done in the field of coronary artery disease. And as far as I know, this is the first study performed in heart transplantation, which is really exciting because, as many of you know, we've been able to improve survival after heart transplant significantly in the short-term period, but not long-term. And we need better tools to risk stratify our patients for longer-term outcomes such as CAV and mortality. And so I hope that these novel tools such as CH can really help us better understand the trajectory of our patients after heart transplant. And so I really look forward to the larger study that Dr. Billia and her colleagues are working on presently. So I'd like to invite all of you to a future event that we're planning, which will be a panel discussion with experts in the field, further discussing these two papers. The date will be posted shortly, and I'd like to invite all of you to attend. And finally, I'd like to thank the HAT for organizing this webinar today and to the discussants, Dr. Kobashigawa. Thank you very much.